Good morning. I am Dr. Anil Parikh, Medical Director, IPCA. It's a great pleasure and privilege for me to welcome you on behalf of IPCA to this academic fest cardiometabolic update. And this program is also being broadcasted online. So there are medical fraternity who are also seeing this program online. And since the hall is a little longer, I would request those who can come forward because there are empty chairs and you will have a better visibility and better hearing. I think today I can really say it's an academic fest because we have three giants in their own fields. With Dr. V. Mohan on diabetology, the talk will be given by him, and Dr. Venkatram, which we all know is has a tremendous contribution in hypertension. So we'll have a talk on hypertension. And then Dr. Narsingan has of late contributed significantly to the lipid association and lipid guidelines, Indian lipid guidelines. So he will be speaking on the lipids part. And before that, I would just like to briefly mention what work we have done at IPCA so that can you put the So what initiatives we have taken at IPCA clinical research initiatives? So turning basic research into medicine is what you call translational medicine. And the odds are not good because, as you can see, this is a 1983 reference from American Journal of Medicine, where you see that out of 101 discoveries, only a few could get 5 could get translated into phase 3 studies, and out of that, only 1 was a successful treatment. So it's not easy to translate that. I will skip that in the interest of time. So these are the 4 areas, major areas I would like to just briefly mention where we have made a beginning. One was the therapy gaps in the safety of NSAID. When I joined IPCA, it was in the year 2000. It was the era of COX-2, highly selective COX-2 inhibitors, where MSD Merck had introduced a drug rofecoxib. And the phase 3 study showed that, it was compared to naproxen. And the phase 3 study showed that it is GI safe because it is highly selective towards COX-2, but it came at the CV safety. And this is where the Merck explained to the regulator that it is because naproxen is like aspirin, it is cardioprotective, and the regulator, this explanation was okay to the regulator. But I thought that if you are non-selective, you have GI side effects. You are highly selective, you have this problem. So you need to get a drug which is neither very highly selective nor so. And I found aceclofenac, and we did a study. And today, aceclofenac is the largest oral selling NSAID in India, and our brand is the one which is contributing significantly to. So this is one small innovation I think gave a lot of a lot of good thing to IPCA, and today it is almost 1,000 crore revenue every year for IPCA, this particular product. We also made it, since it's what is twice daily by the innovator, we made a once daily preparation, and it was published in the Journal of Pain. So this is the second innovation where, in 2003, ALHET study, which is the largest hypertension trial involving over 42,400 patients, were published, where clothianidine was compared to the newer drugs at that time, to calcium channel blocker amlodipine and to the ACE inhibitor lisinopril. And surprisingly, clothianidine came better than these newer drugs on secondary endpoints, particularly heart failure. And while on MI and stroke, it was similar to other drugs. So this is where I thought that we need to work on this drug. And since it was low dose of hydrochlorothiazide and chlorothiazide are considered similar, 25 and 12.5. But chlorothiazide being 2 times more potent, we conceived a 6.25 milligram dose and did a series of studies. This is where I received the New Investigator Travel Award from University of Mississippi for the first combination of ARB and chlorothiazide. This is where we did a 24 hours ambulatory blood pressure monitoring study. This was published in JACC. And then we showed that after 10 p.m. in the night, hydrochlorothiazide loses its antihypertensive efficacy, while chlorothiazide being a long-acting drug, it continues to work throughout 24 hours. And this came in the Braunwald's textbook of medicine. So this was the second initiative which we took. And the third is, the link between diabetes and inflammation is well known. Chronic inflammation drives diabetes complications as well as progression of diabetes. And one of the reasons of why the type 2 diabetes patients have a high CV risk. And rheumatoid arthritis, again, chronic inflammation is the common factor between the two. And this is the study which was published in JAMA in 2007. This made me think about, thinking of hydroxychloroquine in type 2 diabetes. This study showed, this is a prospective observational study of, almost 22 years, where the University of Pittsburgh, they followed 5,000 rheumatoid arthritis patients over the next 22 years, and to see which one develops diabetes. So those who took hydroxychloroquine for 4 years or more, they had much less chances of developing diabetes. So this is where, hydroxychloroquine has a potential to prevent diabetes. So this is the most significant one. So I thought that since prevention of diabetes I could not carry out, so I did a study where type 2 diabetes, I searched the literature, and there were 2 studies where it has been used previously, one by Justine and one by an Italian investigator. So we did a phase 3 study and got it approved in India at around 15 medical colleges across India. There are various other applications of this drug. So far, I have not succeeded in carrying out, but I have done a lipid lowering study as well, where it prevents statin-induced diabetes. And also, I have done an antiplatelet activity study, because the literature shows that hydroxychloroquine is antithrombotic, and it was used by Chanley in UK before heparin came to prevent deep vein thrombosis in patients undergoing hip arthroplasty. So there was no human antiplatelet study available, so that was done there. So this is the last is we have clopidogrel is a drug very widely used and an antiplatelet drug, but almost 30% of the Indian population does not carry a gene which can metabolize this drug. This drug is a pro-drug. It needs metabolism to get converted into active metabolite by 2 steps. So what we have, so in 30% of the patient, it doesn't act. And that's why there is a box warning on clopidogrel that those patients who cannot metabolize it, those who are CYP2C19 deficient pharmacogenetically, they use another antiplatelet drug. So we have made a metabolite directly clopidogrel intermediate metabolite, and with this we are able to overcome. We have done phase 1 study, and we have just received permission from DCGI to carry out phase 2 study. So these are some of the few innovative studies. So I thought I will share with the audience. And now what I would like to call is Dr. V. Mohan to come on the dais. I think we will. Can you put the slide? Dr. V. Mohan is next. Dr. V. Mohan, we all know actually throughout India, and I can say, I think he's the living legend of diabetology, the tremendous contributions. Whenever I look at him, I see tremendous contribution of clinical practice, tremendous contribution in academics, and with publications, which I don't think it will be possible for anybody else to match his publications. And so ideal thing which you want, you want a good mix of clinical practice, academics, and public publications. So this is research work. So this is where I think Dr. V. Mohan is there. So since we are in the interest of time, I think all the Chennai audience, not only Chennai audience, but even the all India, Dr. V. Mohan is well known. And not only here, I was very pleasantly surprised in ADA, he was also talked about by the ADA president. So his achievements are such that he is well known everywhere. I would request Dr. V. Mohan sir to kindly give his talk. Thank you, sir, please. So much.
Can get the pointer that's laser pointer. Sitting down. It's okay. Good morning, ladies and gentlemen. I think it's first of all, thank you to IPCA, particularly Mr. Johnny Edwin, who has been following up on this. It's a great honor for me to be present here today in the presence of two doyens in the field. I think whenever you talk about hypertension and its treatment, you cannot, even at international level, you cannot but talk about Dr. Venkat S. Ram, who has spent his whole life, it can be considered among the top 4 or 5 people in the world in the field of hypertension, not only in India, but globally. And so it's a great honor to share the same platform with him. Dr. Narsingan, whom I have known now for several decades, is equally competent not only in hypertension, but his favorite field being dyslipidemia, in which he has contributed so much. And much of the Indian guidelines come from his work with Raman Puri and others as part of the Lipid Association of India. Very kind of them. They've been mentioning for some time that, and they're both, representing the World Hypertension League, about which they will talk a little bit. And even earlier, on an earlier occasion, they had honored me once and they wanted to do it again. So I'm very humbled to receive the felicitation and the honor from them. So thank you very much to both to Dr. Venkatram and to Dr. Narsingan and to the whole of IPCA, and to all of you for having come on a Sunday morning to be present here. So I've been asked to speak on, so I'll make the talk quite short. And the focus, obviously we cannot cover the whole of diabetes therapeutics, and IPCA particularly wanted me to talk on sulfonylureas. And I think it's very important because old, as they say, is gold. So as the newer and newer drugs come in, it doesn't mean that the old ones are bad. It's just that the new ones come with more facilities. I always compare it with a car. So the latest car, the latest BMW, the latest Rolls-Royce, and the latest Mercedes-Benz, there is no doubt at all that they are fantastic cars. There's no doubt about it. But many can't even afford it. In fact, the first time I entered into a Rolls-Royce was about 3 days ago, when I had gone for a dinner and one of my friends has bought a Rolls-Royce. And I have a humble Toyota only. So he said, he'll drop me home. And I said, no, I'll walk home, because from the hotel I could easily walk home. He said, no, I have to sit inside a Rolls-Royce. I said, oh, that's correct. Once at least sitting inside a Rolls-Royce is a good thing. So I had the opportunity to sit with him inside a Rolls-Royce. It's my only connection to a Rolls-Royce that I have. So why I'm bringing that up is many of the, and of course it's a fantastic car, there's no doubt about it. But if you talk about old things, and if you talk about the old Maruti, it doesn't mean the Maruti is a bad car. It is still a good car and it still serves the common man. And so therefore, will I give up sulfonylureas? No, I'll never give up sulfonylurea as long as it's available. Do I use sulfonylurea? Of course I use sulfonylurea. Many of my patients, I still use it. It's not a bad molecule at all, as I'll try to convince you. Of course, this is an IPCA sponsored talk, so I have to put my conflict of interest, but I also work with many of their competitors and the list is quite long. So let me just give you one slide so that we are all on the same page. These are the numbers, official numbers published in 2021 by the International Diabetes Federation. Of course, these numbers come from studies that we ourselves do. For example, the 74 million comes from the ICMR INDIAB study. The IDF will write to us and say, what do you have the latest information? And the latest information is coming from the INDIAB study. And confidentially, I can share with you that although the 74 million is put down by the IDF, we have a paper which is under review in Lancet Diabetes, which should come out now. There, if that paper gets accepted, and I hope it gets accepted, the numbers for India will go to 95 million straight away, not 74 to 76, because we have now completed the INDIAB study. These numbers came when half of INDIAB was done, and 7 of those states were from the Northeast, where they had very low prevalence. And IDF will go only by the published figures. You can't say, no, Kerala will be higher, this will be higher. They'll say you publish it. Yeah. Sorry? I was in this one. What happened? Slider was not. Oh, that is a share. Okay. To cut a long story short, I think these numbers are underestimates, and we are going to see not 124 million after 20, 30 years, it's probably more like 150 or 200 million people. The rate of rise is just too fast. When this 74 million came, out of the 15 states completed, 7 of them were in the lowest prevalence rates in the Northeast, where people do a lot of exercise, they're not that rich, and so on. Now, with the southern states being completed, Kerala, Puducherry, prevalence rates are going sky high. And now we're repeating the study now in Tamil Nadu because 10 years. So Arunachal Pradesh and Tamil Nadu has been selected for redoing it. And within 10 years, it's unbelievable how much it has increased in Tamil Nadu. So these are moving numbers. Suffice to say that we have large numbers of people with diabetes. And can all these 74 million people afford the latest drugs for diabetes? They can't. So therefore, for the common person, it is still very important. Sulfonylureas, in fact, were one of the first of the oral anti-diabetic drugs to come. Right from 1940s, there was work on it. And by 1950s, the first drugs, tolbutamide and chloropropamide, had come. And since I started very early in my life, at the age of 18, I started working with my father, I've used tolbutamide. It used to be called Rastinon. And chloropropamide was also Diabenese. It was also used. These are only drugs which are available. In fact, in 1970, you see that landmark. 1969, to be precise, was when my father was part of the development of glibenclamide, the second generation sulfonylurea. It's a dramatic change from tolbutamide, chloropropamide to glibenclamide. At that time, it was a fantastic development which occurred. But then we had the second generation, third generation. We had safety from UKPDS. So we had glipizide and glycoside coming in, about which I'm going to talk today. And then we have also the glycoside extended release, glimepiride, third generation. So sulfonylureas have not stopped coming. They're coming better and better. And the modern sulfonylureas are actually comparable to DPP-4 inhibitors or any of the latest drugs. So how are these modern sulfonylureas different? Because they have a unique mechanism of action. I think the top line is getting hidden. So they have a differential affinity for the sulfonylurea receptor. And because of that, they bind more easily and the release mechanisms are different. This actually translates to better safety, lower hypoglycemia. So the modern hypoglycemic, the modern sulfonylureas don't have the severe hypoglycemia, which is, for example, even with glibenclamide, which is, it's not a drug which I'd use in old people anymore because you've got much safer drugs. The most popular modern sulfonylureas are glimepiride and glycoside. I would say more than 90-95% of all the sulfonylureas used in India will be one of these two. And this talk will focus on glycoside, although this company produces both, but they wanted to focus on glycoside. So if you look at the glycoside, is there any way I can get rid of that top thing? I don't want to do something which will. Can you pull it down? Lift it up. Okay, now it is seen. Okay, so glycoside in the advanced trial, that was a turning point. We were involved in the advanced trial, and part of India's many people who are involved in the advanced trial, which was done by the George Institute. Now, in the advanced trial, what they showed was something very unique, and this slide I think is very important. With any drug, when you try to get the A1C down, up to 7%, there is no problem. But if you try to bring it to 6.5, you're already going to get hypoglycemia. And to bring it to 6% is almost impossible with many of the drugs. You can't do it with glibenclamide, for example. In fact, two trials, the VADT trial and the Accord trial, had to be stopped because people died. And they tried to get the A1C down to 6, and the trial had to be stopped. But in the advanced trial, you can see 81% of the patients had a A1C below 7, 65% had below 6.5. No other trial has shown this. And below 6%, 21%, 1 out of 5 on a sulfonylurea, able to get the A1C down to below 6. There were no safety issues. There were no deaths, no severe hypoglycemia, no hospitalization for hypoglycemia. And you can see how it is sustained for years. They say after use sulfonylurea, sometime it will burn out. No, it's not. For 6 years, 7 years, they're able to continue like this and even longer. Some technical issues are there. Okay, so this low risk of hypoglycemia with glycoside is very well known. It has a biphasic pulsatile glucose-dependent insulin secretion. That means only when the glucose levels are high, it works. So when it's having hypoglycemia, it doesn't work that much as it should not. And also restoration, the early insulin peak. We know that insulin secretion occurs in the first phase and second phase. And the first phase, loss of the first phase, that big thing which goes up, that is the primary defect in type 2 diabetes. And that is corrected by giving this particular drug. Now, is it recommended if you have a kidney problem? Now, these are the Kidney Disease Outcomes Quality Initiative, or the KIDOGI guidelines from the National Kidney Foundation. And you can see that whereas glimepiride, you have to be careful if the eGFR is below 30. It's not recommended even because it's a long-acting drug. Whereas glycoside, below 60 you can use it, below 45 you can use it, and below 30 also you can use it. Of course, the dose you might have to reduce or give it once a day if it's an extended release, but it can be used without dosage adjustment in early stages of kidney disease. As I mentioned, the VADT and Accord, apart from the deaths, there was also a lot of weight gain. Whereas in advance, you can see there was no weight gain. Can you believe a sulfonylurea drug which is used with no weight gain? So it just shows why glycoside has continued to rule the roost, so to speak, as far as the oral drug therapy is concerned, even today. Now, this weight neutrality is actually maintained over years. Even in later studies which came, even with the glimepiride, the Carolina trial, for example, showed that there is an initial weight gain. But after that, the weight actually plateaus and actually comes down in Carolina. So this weight gain that we talk about is sulfonylurea. As far as the modern sulfonylureas are concerned, it is more of a myth. Now, glycoside is a sulfonylurea with a difference for the following reasons. First of all, it has a unique mechanism of action. It works specifically on the sulfonylurea receptor on the beta cell. Its efficacy is unparalleled. It will be no exaggeration, whether it's an IPCA talk or any talk, to tell you that there is no anti-diabetic drug in the world today among all the classes that you have to beat a sulfonylurea. Will you believe that or not? Sulfonylurea and metformin, the oldest drugs, are the most potent. You can get an A1C reduction of 2%, 2.5%, unmatched. You cannot get it with DPP-4. You cannot get it with SGLT2. You cannot get it with the GLP-1 receptor analog. So as far as potency is concerned, nobody in the world is going to say sulfonylurea is not potent. It's the most potent. What they are afraid is it too potent? Will it get hypo? Well, you can have the modern one. It doesn't produce hypoglycemia. Cardiovascular safety has been shown, not only in advance, but also in Carolina, where the glimepiride and linagliptin had no difference as far as the cardiovascular. The graphs were one on top of the other. Renal safety, absolutely renal safe. It has no nephrotoxic element at all. And as I just showed, it's been approved by KDIGO to be used even in renal failure. And of course, weight gain is not an issue. So it's a drug of choice in type 2 diabetes management. And I won't say only for a poor man I'll use it. I use it for millionaires and tell them it's a fantastic drug. It's the most potent. Your sugar is severe. I don't think it'll respond to any of the others. And you can even use it in combination. Doesn't mean you cannot combine SGLT2 with this or GLP receptor analog with this or metformin with this. In fact, when I was a student in Madras Medical College, one of my early papers, the third or fourth paper I published, was a combination of sulfonylurea and metformin in dogs. We did dog experiments in Madras Medical College. And then with my father, we did the clinical trial. Those are the first 1974, 75, almost 50 years ago. We have shown that the combination of these work. This is just a small study which we did publish in 2015, where we looked at the extended release glycoside formulation. Objective was to see a simple two-step titration. Can you start with a lower dose and then build it up? And so this is the trial protocol. I won't go through that. So we used a two-step thing. You start with 60 milligram. Then if it doesn't work, you give 1.5 tablets, 90 milligram, because it's a scored tablet, so you can break it. And then you can go to 120 milligrams. Worked beautifully. This is about 700 patients. And as you can see, beautiful effect on fasting blood sugar. Almost you can see and of course it's dose dependent. So as you go higher in the dose, you're getting a significant reduction in the fasting blood sugar. There's post-meal blood sugar reduction, also an A1C reduction of 1.3%. Now this is in a clinical, in a real world evidence. And if you do it in a clinical trial where you select the patient, you'll get probably much more. As I said, you can get up to 1.5 to 2% reduction. Lipid profile, well, it's definitely not having any bad effects. It's not a lipid-lowering drug, obviously, so it's not a statin. But we are seeing some improvement, slight increase in HDL and reduction in triglyceride, reduction in the LDL also. Because of the control of diabetes, you get some improvement in the lipids as well. As I said, the incidence of hypoglycemia, very low, not a single case in the trial we had to withdraw because of severe hypoglycemia. So this paper, which we published, highlights Indian evidence to show that 80% of patients are treated with oral drugs, only a third who achieve HbA1c less than 7%, because you're using very mild drugs, probably not using the proper dose, and you have drugs like this which you can use to bring it down. And this is another study from India showing the real-world effectiveness of glycoside or glycoside plus metformin. And you can see that a lot of people achieved the target of the A1C. And if you use the glycoside alone, or you add glycoside plus metformin, you're obviously getting a much better effect. And you can see that in patients with A1C more than 7, it worked, and more than 6.5. These are relatively milder cases, and even there, it has been used safely. And the conclusion from the study is that glycoside can be an ideal choice if sulfonylurea is being considered. There is other evidence from the UK as well. UK was one of the first to use glycoside. In fact, when we were using other drugs like glibenclamide, they use glycoside, but of course for a different purpose. For some reason, glibenclamide, which is so cheap here, was costly in the UK. So because it was cheap, this was a drug which was used in the UK right from the beginning, 20 years. Ever since UK PDS, they used only this. And they've got a lot of experience with the glycoside. George Alberti and others have used that. And here is real evidence, real-world evidence to show that it really works. And this is top people like Melanie Davis and Kamlesh Kunti and others who have shown the real-world effectiveness compared to sitagliptin, almost similar with very little difference in hypoglycemia as well. And glycoside MR is 35% more likely to achieve an A1C less than 7%, and here is less than 6.5%. Now, this is not something which other companies will tell you, or other molecules you can say. 6.5% HbA1c. Tell me how many conference you attended where people are talking about A1C of 6.5. It's difficult. If you're really aiming for tight control, you sometimes need a sulfonylurea. And you can see the sitagliptin is not able to match the number of people who are achieving 6.5. Ramadan is one of the indications for using glycoside. Lots of studies have been done. We have also done one, and others have also done, because that's the time when you fast. And when you fast, you don't want a drug which will produce hypoglycemia. If you stop the drug, they'll get hyperglycemia. If you take the drug, they'll get hypoglycemia. So can you use a sulfonylurea? DPP-4s are promoted for that, saying that you can use it. And of course, you can use DPP-4s. But here is a study which showed that even during Ramadan, 1,200 patients studied with glycoside modified release, Virtually no hypoglycemia reported with this. The patients were treated with glycoside MR have a low risk of hypoglycemia and they're able to take it. So there is no need. Of course, now the Ramadan field has gone far ahead. I'm very much involved in some of the research studies. They have guidelines now. When Muslim patients come, you can classify them and say low risk, medium risk, high risk. The very high risk patients, you can actually tell them not to fast, because it is dangerous. But the medium risk and the low risk, you can. But some of the high risk Muslim patients, they'll say, no, I want to fast. Even if you tell me it's high risk, I'll fast. So we've used it in such people and they've been able to take it. So although the risk is there, but God above does many more wonders than we can do. And therefore, if you want one drug, you can use a DPP-4 or you can use glycoside. So I'm going to stop with this by giving you only 3 messages. One is the efficacy and safety of sulfonylureas in general, and glycoside MR is well established to many RCTs. Even more, we have real-world evidence studies of glycoside complementing the RCT data of glycoside and glycoside MR. And glycoside and glycoside modified release can be safely used to navigate type 2 patients. I like the word navigate. Navigate type 2 patients safely towards individual euglycemic roles in routine clinical practice. And this includes bringing A1C down to even less than 6.5. We always talk about 7%, but you want a drug where you want to hit harder in a younger patient. You don't want to have any hypoglycemia. You don't want to have hypoglycemia, and you want to bring the levels down. Consider a sulfonylurea, and you can definitely consider a modified release glycoside. And with that, I'll stop. Thank you. And if there are questions, we'll take it after. Thank you very much.
Thank you, Dr. Mohan, for an excellent talk on glycoside, sulfonylurea, and reminding us that still there is a place for sulfonylureas despite the arrival of so many new drugs. And not only that, it is not just a question of cost effectiveness. It is also that when there is a significant hyperglycemia, then you still need the sulfonylurea. Thank you, sir. Now I would request Professor Venkatram to kindly come and address us. I think I'll just I think he is also well known in India as well as internationally. So currently he is Director, Apollo Institute of Blood Pressure Management and Apollo Blood Pressure Clinic. He is Director, World Hypertension League, and he is the Editor-in-Chief of Hypertension Journal. And he has been associated with the Dallas, Texas Institute. And I would request him to kindly, yeah. And he is again, I will say personally, because I have known him since I was a resident in Nair Hospital. And since those days, Dr. P.J. Mehta used to collaborate with him. So that's how I know him since my residency days. So that affection is different. And I have learned over the years from him in the hypertension. And sir, over to you.
Thank you very much, Dr. Parikh. Good afternoon, ladies and gentlemen. I have an allocated time. I will finish during that allocated time, but during that allocated time, I will deviate from what I wanted to show and say a few things about Chennai and Tamil Nadu. I have always been fond of medical practitioners in Tamil Nadu. I have always been fond of medical practitioners in Chennai in particular. I have said this in many forums. Due to the changes in the medical field that are happening, some of which are not that great, I always feel that Chennai is a last bastion of integrity of medical science and how to practice it. If the flag falls here, the flag falls everywhere. So I want to offer the tribute to all the doctors here, and I say it publicly. I am from Hyderabad. I was born in Machilipatnam, Andhra Pradesh. Doesn't matter, because I have to say the way it is. So please continue to safeguard the importance of the medical field, and you will do it. I want to say few things about blood pressure, vascular disease, and the new blood pressure goals. And then a trial that was published recently in New England Journal of Medicine, where the conclusions are very, very peculiar, and I want to show that. So ladies and gentlemen, when we treat hypertension, you want to prevent atherosclerotic complications of hypertension. So when you see a patient with high blood pressure tomorrow in your clinic, you're not thinking about hypertensive encephalopathy. You're not thinking about aortic dissection. You are thinking of preventing heart attack, and you are thinking of preventing stroke. And those are all due to vascular disease. Now the question is, does high blood pressure independently causes vascular disease? Ladies and gentlemen, these are the aortas of young people who had only one diagnosis, that was high blood pressure. Can you look at these aortas and imagine what is happening to them as a result of elevated blood pressure? Now I'm going to show a slide which is experiment of the nature. This is, nature has done this experiment called aortic coarctation. Some of you may have occasionally seen aortic coarctation. Aortic coarctation, the blood pressure is high above coarctation and it is normal or low below coarctation, right? Above coarctation, high blood pressure. Below coarctation, low blood pressure. Ladies and gentlemen, this is the aorta above coarctation, thickly populated with atherosclerosis. Below coarctation, nice, it is like a silk, nothing touches it. So ladies and gentlemen, I made my point. High blood pressure causes atherosclerosis. Normal blood pressure or low blood pressure prevents atherosclerosis. Don't believe those pundits who come on national networks, who give commentaries on Hindu and Times of India, that the blood pressure is a made-up thing. It does not exist. Don't believe despite their qualifications. Trust me, high blood pressure is dangerous. Normal blood pressure is desirable. Now, let me take you back to nearly 100 years back. Nearly 100 years back. 100 years back, the best blood pressure was shown to be 120/80. If you increase the blood pressure by 10 millimeters of mercury, you lose 4 years of life. If you increase the blood pressure further, you lose 8 years of life. If you make the blood pressure 150/100, you lose by 16 years. Ladies and gentlemen, can you believe 100 years back, we were told that best blood pressure to have is 120/80. So please, biologically, population sciences, scientific evidence suggests that blood pressure should be under 130/80. Anything higher over the period of time is not desirable. Now, all the guidelines now are coming to a reasonable consensus that systolic blood pressure should be less than 130, if possible. I'm not saying it's possible, if possible. This is a slide showing that the blood pressures that are less than 130, all shown here, these are the blood pressures less than 130, there is benefit. If the blood pressure is more than 130, there's no benefit. So why do you want to compromise with the patient? 135 is okay, 140 is okay, come back after 6 months, come back after Sankranti, come back after Ugadi. Why do you compromise? Anything less than 130 is desirable. Anything about 130 is not helpful. Now, they say elderly people, we have a culturally, we tend to relegate elderly people as if they should not live. That's how the culture is. They say somebody sees a elderly patient with blood pressure of 170. I have seen doctors telling it's normal for your age. There's no such thing. Trust me. Look at this slide showing that when you lower the blood pressure in the elderly, all the cardiovascular complications are reduced. So why do you want to condemn the elderly people to get a stroke and heart attack? Please don't do that. As long as they're mobile, able to talk, able to walk, and be part of the society, bring the blood pressure to normal, as much normal as they can tolerate. That's all. Now, we have this tendency, Dr. Mohan and Dr. Narsingan, they treat diabetes and lipids. They also have patients who will say, sir, my sugar is only slightly high. And then somebody says, Narsingan, sir, I just went to a wedding last night, so my cholesterol is slightly high. This slight, they use the word slight. Once you use the word slight, you lost the patient because they already made up their mind slight. Now look at the slight increase in blood pressure, 120 to 130, 130 to 140. What happens to cardiovascular mortality and stroke? If you increase the blood pressure from 130 to 140, there is a 56% increase in the cardiovascular mortality. There is a 100% increase in stroke. So don't believe in this little bit slight and all these things, because there is what is known as a cumulative effect. Ultimately, it catches up with passage of time. So be careful. So ladies and gentlemen, Mr. Chairman, the definition of high blood pressure is 130 by 80. What guidelines you want to follow, it is up to you. But don't sacrifice the health of the patient. Majority of cardiovascular events occur under the blood pressure of 140 over 90. Please pay careful attention to what I said. Majority of cardiovascular events occur under 140 over 90. That means they're occurring between 130 to 140, between 80 to 90. If somebody has 200 over 120, you don't need anything to tell the patient. If somebody has 190 or 140, they don't need, even the housekeeping person in the hospital will tell, Amma, your blood pressure is very high. Okay, so this is 130 to 140, 80 to 90, that's where our challenges are. Now, South Asians and Dr. Mohan, in diabetic field, obviously, he is the one who has contributed to diabetes as a science and population science from South Asia. Once you are South Asian, namely Indian, your cardiovascular risk at any level of blood pressure increases by 40%. One more thing I want to tell you, when people use the word South Asia, it's a very political term. It's a very diplomatic term. It means India. We're not talking about Bangladesh. We're not talking about Sri Lanka. We're not talking about Nepal. We are talking about India. But all organizations are very shy. They use the word South Asian. We're not talking about Pakistan. They're talking about you and me. Tremendous increase. Now, Americans also have characterized Asians as a high cardiovascular risk. World Health Organization and WHO, our Vice President is here, they have characterized South Asians as high risk. So ladies and gentlemen, our genetic background has already predisposed you to high risk. Now, I want to take another 10 minutes to talk about not less than 10 minutes, about a trial that was published in New England Journal of Medicine about 2 months ago. New England Journal of Medicine is one of the highest so-called impact factors. Its last impact factor is 176. With due respects to India, due respect to all of us, Indian Heart Journal impact factor is 1.4. Okay, with due respects. New England Journal of Medicine impact factor is 176. So everybody wants to read New England Journal of Medicine. But please be careful when you read trials in high impact thing. They're publishing it little bit for science, but little bit more for publicity. Trust me, little bit more for publicity. And I'll show you one. In fact, I use the word, which I'm going to write a commentary, trials and tribulations, I'll read. Anyway, the recent trial was about chlorthalidone diuretics. This is a slide showing that so many clinical trials which have used chlortalidone as a diuretic are pivotal outcome trials have shown improvement in cardiovascular outcomes, and trials comparing hydrochlorothiazide and chlortalidone have consistently shown that chlortalidone at half the dose of hydrochlorothiazide is very similar at the half the dose. And these are so many trials which have shown that, trial after trial. And this is a comparison between chlortalidone and hydrochlorothiazide, showing the benefit towards chlortalidone compared to hydrochlorothiazide. I am not opposed to hydrochlorothiazide. I am not opposed to anything. Only scientific evidence. I'm not for or against, but you have to see the scientific evidence when you're choosing a drug. And this is meta-analysis showing the benefits of it. Now, okay, this is a major study that was done by Dr. Rajiv Agarwal, who is in Indiana. He wrote an editorial in Circulation where he said thiazide like diuretic should be used when initiating or changing diuretic therapy as quoted from National Institute of Health of Excellence in UK. And in Journal of American Medical Association in 1982, CTD be the only diuretic for step 1 control of hypertension. So this comparison has been going on for quite some time. It's not going to end also. And my former colleague, partner under whom I trained, who passed away, he wrote this editorial, Chlortalidone versus hydrochlorothiazide, a tale of tortoise and a hare. This is the story that we always know as children, and you know who the winner is, either the tortoise or hare. He wrote a very beautiful editorial. Now, these trials and tribulations, and let me show very, very quickly. And this is a trial in New England Journal of Medicine comparing chlortalidone to hydrochlorothiazide comparison project. And they compared 25 milligram of hydrochlorothiazide with 12.5 of chlortalidone. And what they have shown was, the conclusions were that chlortalidone appears to be beneficial compared to hydrochlorothiazide. That was their conclusion. But let us look at the actual results, which are in form of table. When it is a form of table, sometimes we also get confused. So I converted them into figures. So when I looked at the primary outcome, there was no difference between hydrochlorothiazide and chlortalidone. 10.4%, not significant. Chlortalidone was 12.5, hydrochlorothiazide was 25. Now, when they look in another way, very, very similar. When you looked at patients with previous cardiovascular disease, chlortalidone was slightly better than hydrochlorothiazide, better. Now, patients were taking hydrochlorothiazide for a long period of time, and they were taking chlortalidone for a short period of time. So one way to look at it is a short-term exposure to chlortalidone is as good as a long-term exposure to hydrochlorothiazide. This is not in a paper. This is something that I have drawn. Hydrochlorothiazide patients were taking it for a long time, but chlortalidone group was added in the beginning, in the middle of the study. So one can turn around the tables and say short-term exposure to chlortalidone is as good as hydrochlorothiazide. In fact, I had written to the authors about it. So, ladies and gentlemen, despite the headlines, when you break down as a clinician, I broke this down. I didn't see any major difference at all. Now, they provided equal protections, and the annual 2.4 year data are very similar, and chlortalidone at low dose is as good as hydrochlorothiazide full dose. And remember, hydrochlorothiazide 25 milligram is not available in India. Am I right, Anil? Yeah, it's not available. So, conclusion, another conclusion, sensational conclusion. the data are not applicable to India at all, right? When you compare 25 and 25 is not available, don't get too much moved when they say hydrochlorothiazide and this thing. Hydrochlorothiazide 25 is not available in India. Now, one of the investigators who authored the paper and suggested that chlorthalidone might be superior to hydrochlorothiazide in the original paper, in a personal communication to me, exactly a month ago, day after tomorrow, he wrote to me saying that CTD and hydrochlorothiazide have similar effects on primary outcome. Hydrochlorothiazide 25 is equal to CTD 12.5. And he wrote to me saying that it does not change his clinical practice. I have no doubt chlorthalidone lowers the BP better than hydrochlorothiazide at commonly doses used. Why did he write that? Because I sent him pointed questions. These are the questions, and please respond. And he responded. Very nice man, very good fellow. And another investigator, by the way, this is my last slide. Another investigator who also misled in the official document by the conclusion, he wrote to me January 11th, not far ago. Personally, this is an investigator now talking personally, which is okay. That's okay. We're all persons. Personally, I believe that better BP is achieved with chlorthalidone at pharmacologically equal doses compared to hydrochlorothiazide. But as Bill Cushman has pointed out, no clinical trial has been demonstrated with hydrochlorothiazide 25 and chlorthalidone 25. Doses of CTD less than 25 has not been tested in clinical trials in abroad. That is correct. They have not been tested, but they have been tested in India. And he also says they probably will never test it in US. So ladies and gentlemen, the reason I'm saying is when you look at the clinical trials, if you really want to do something, try to lead in between and try to do what is best for you and what is best for the patient and the patient's community. So that is the reason why when big clinical trials come, there is a major publicity, but you should pay some attention to it. So, Mr. Chairman, ladies and gentlemen, in the time that was allocated to me, I gave you a kind of a very abbreviated and somewhat rewrote application of the recently available data for the best benefit of our brothers and sisters in India. Thank you very much.
Thank you, sir. Thank you, Professor Venkatram, for an excellent display on hypertension in general, pathophysiology, and the various treatments. Now I would request Dr. Narsingan to deliver his talk. Dr. Narsingan is very well known across in Chennai audience. I think he's well known, but even across India, he's well known. And he's currently the Vice President, World Hypertension League, and the Vice Chairman also of the Lipid Association of India, immediate past President of Indian Society of Hypertension, and elected Fellow of the International Society of Hypertension. And he has a Managing Director, SNN Diagnostic Center and Specialty Clinic, Chennai, published expert consensus and recommendation on lipid management. He has been conferred the Lifetime Achievement Award by Tamil Nadu, Dr. MGR University, and a Master Teacher Award. Actually, what I see is over the years, I have been hearing him in various conferences, and I have come to admire him over the years, and he is really very, very knowledgeable and very, very insightful. And the Lipid Association guideline of Association of India guideline, which they mentioned, I think they were even ahead of the international Western guidelines in recommending very aggressive lipid management for patients who are at very high severe risk, who already has a cardiovascular disease. I think the Lipid Association of India, with Dr. Narsingan's contribution, they made this ahead of even the Western guidelines of US and Europe. So with that, I think I would request Dr. Narsingan to deliver his talk.
Thank you, Chairman Dr. Parikh, for the excellent words, and Dr. Venkateswaran, respected Dr. Mohan, and my dear friends. Good afternoon, everyone. My topic is on dyslipidemia therapeutic update. We need to remember about the burden of cardiovascular disease, what we are facing. Globally, it is about 31% of all deaths occurring is only due to cardiovascular disease. It is also the leading cause of premature death between the ages of 30 and 70 years. It is clearly seen in the data that about 54.5 million people suffer from cardiovascular disease in our country. Approximately 25% of the deaths occur only due to atherosclerotic cardiovascular disease. With respect to prevalence of hypercholesterolemia, it is estimated that about 10 to 15% of rural population and 25 to 30% of urban population suffer from hypercholesterolemia. In the first phase of ICMR INDIAP study, 13.9% of the study population had hypercholesterolemia and higher levels of LDL cholesterol ranging 11.8%. We need to remember this important message, which is derived from various data available in our country. 40% of Indians with coronary artery disease are less than 40 years of age. 25% of those dying due to coronary artery disease are less than 40 years of age. In Indians, coronary artery disease develops 1 decade earlier than other ethnic groups, more severe coronary artery disease and high mortality. As has been rightly pointed out by Dr. Venkatesh Ram, South Asians are at a higher risk group, as has been dictated by American College of Cardiology. We try to recollect what is available in the literature. Way back 1933 in Arteriosclerosis journal that was mentioned about atherosclerosis. In the absence of hypercholesterolemia, that is raised LDL cholesterol or remnant particles, it is virtually impossible to cause atherosclerosis in an experimental animal. All of us know about this elegant study done by Salim Yusuf and his group, Interheart study, which had evaluated 9 commonly occurring reversible cardiovascular risk factors, out of which dyslipidemia or ApoB-A1 ratio became the #1 risk factor for pushing patients for an acute myocardial infarction. It is also true in another study, Dr. Mohan was also part of the study, PURE study, where they had evaluated the risk factors. Hypertension was the most important risk factor. Next, almost equal to that, is a lipid, particularly in South Asians, when compared to the global data. There are 3 test tubes with this. Only the plasma, which is depicted here. On to the left side, you can just see it is yellowish in color, which contains more of LDL, more probably of LPA, responsible for increased cardiovascular events. When you have hypertriglyceridemia with an increased levels of remnant particles, triglyceride-rich lipoprotein particles, you have more incidence of cardiovascular disease. That is emerging data. When you have abnormally elevated triglyceride, more than 2,000, 3,000, then they have problems of chylomicronemia. Actually, the plasma or the serum is turbid, which is responsible for increasing pancreatitis and less of cardiovascular disease. If you look at this data, you will understand that the LDL cholesterol, which is maintained throughout the life of an individual, probably plays a role for him to get pushed for an early myocardial infarction. If you have people with 80 milligram of LDL cholesterol, his chances of getting myocardial infarction at the age of 100 years. Whereas if somebody has LDL cholesterol 125, which is maintained throughout his life, it is likely that the lifespan gets reduced to 64 years when he may get myocardial infarction. Suppose somebody has 200 milligrams and above, it is clearly seen that the risk of getting myocardial infarction, as far as the age is concerned, comes down to less than 40 years of age. Excellent information, what we have derived from cardiac study. So, ladies and gentlemen, LDL plays a central role. LDL plays a pivotal role in atherosclerosis. It is our duty to reduce it as early as possible. Clearly seen by various studies, molecular studies, biological information, epidemiological data, observational data. But the best evidence comes from the familial hypercholesterolemia. No other risk factor responsible for pushing patients for atherosclerotic cardiovascular disease other than the cholesterol LDL. It is also seen that randomized control trials which had used statins, HMG coenzyme reductase inhibitors, the more the reduction that was witnessed in primary prevention trials and secondary prevention trials, the more benefit that is seen, not only in morbidity, but also in mortality. Stressing the importance that we need to control the LDL cholesterol all the time to get the maximum benefit that is witnessed not only in primary and secondary prevention trials. People who have received statin, you look at the information. people who received the statin, and if their levels of LDL cholesterol is around 50 milligrams or so, you can just see it's only 4.4% of secondary events. Whereas when somebody is keeping the levels above 100, it is 16%. So the event rates comes down when you lower the LDL cholesterol. So lower the LDL cholesterol is the better. That concept started emerging only from heart protection study, which at first time evaluated the efficacy and safety of statin, not only in primary prevention approach, but also in secondary prevention approach. If you reduce the LDL cholesterol by 50 milligrams, you get a benefit of nearly reduction of 50%. But unfortunately, people who receive statins, many of them do not have probably a capacity to reduce the LDL cholesterol. Nearly 40% of them still keep it at a higher level. These are the meta-analysis data, which clearly indicates that there is a reduction of 22% in the major vascular events, 10% reduction in all-cause mortality in the first one. The second meta-analysis, which had evaluated various therapies, again states 23% reduction. The last one, statin, ezetimibe, PCSK9, 19% relative risk reduction. If you look at all this data which are projected here from primary prevention, secondary prevention trials, it is clearly seen that there's a residual risk. In spite of receiving high dose, moderate dose, tolerable dose of statin, you still get a risk of getting cardiovascular events. What is the range of risk? 55 to 70% of the people are still at a high risk of developing a problem. How to reduce the LDL further? You cannot go on escalating the dose of statin because it may be probably not good to have the same approach for every patient. It all depends on the intensity of the statin what you're using. All that you should do is to select some other drug called ezetimibe, which is available in our country. The study which had focused attention of the safety and the efficacy of using a non-statin drug to that of the statin is the IMPROVE trial, which had evaluated people who have a stable coronary artery disease following myocardial infarction. It is clearly seen that 53 milligram was the LDL cholesterol that was reached by adding only 10 milligram of ezetimibe with that of simvastatin 40 milligram. So the indication of ezetimibe, not only in non-diabetic, but people with the diabetes has shown the maximum benefit. Nearly 14% risk reduction in those people with the diabetes when compared to people without diabetes, just by adding only ezetimibe to the high dose statin. It is also seen people with the diabetes with the polyvascular disease, they get the maximum benefit. The number needed to treat is only 11 when compared to people with only diabetes or people with the polyvascular disease, no diabetes. So compared to all these groups, diabetic persons who have polyvascular disease will get the maximum benefit when they get an additional drug, ezetimibe, over and above high dose statin. That's the message that you derive from this particular study. It is also true that if you are using a statin plus an ezetimibe, it is possible to get the percentage reduction in atheroma volume by the intravascular sound studies. Let me now try to take you to the PCSK9 inhibitor, which is now available in our country. The good old study is ODC long-term study, and the other one is the Osler 1 and 2 studies, clearly indicated if you are bringing down the LDL cholesterol by 50 milligrams, it is possible to get 50% reduction of LDL. You do get a reduction of 50% risk for these patients. So based on all these reports, based on all these studies, based on all meta-analysis, the Lipid Association of India came out with the recommendation that people who are at a very high risk need to keep the LDL levels less than 50 milligram and non-HDL cholesterol less than 80 milligram as per the projections made here. That is what was actually projected in the year 2016. The first organization to come out with this recommendation before European Society or ACCA was talking about the target or the threshold. 4-year trial was a trial which had used the evolocumab in those patients with high risk, nearly about 28,000 patients. One arm received evolocumab injectable. They had given 140 milligram once in 15 days or 420 milligram once a month. And they have followed up these patients for a period of 3.8 years compared to the placebo. Very, very clear to see people who are having 93 milligrams of LDL within a matter of 1 month, they were able to get down to the levels of 30 milligrams. And it was maintained even after 48 weeks of study, continued throughout the period of study, the same reduction of LDL cholesterol was observed, thereby indicating the more the reduction of LDL cholesterol, does it show benefit? Yes, 15% reduction in the primary endpoint was observed when the levels of LDL cholesterol was brought down to 30 milligram. If you look at this data, not only 15%, which is for 30 milligrams, but you bring it down to the levels of 20, you get more benefit. Some people have reached even levels less than 10. Surprisingly, the cardiovascular risk is estimated to be around 31% risk reduction in this group of people. So, ladies and gentlemen, the message is very clear. Do you know how to reduce LDL? We know. How much you should know? Reduce it? We don't know. We are not in a position to say what is the exact lower level of LDL cholesterol beyond which you will not get benefit. That's the message what I thought I should give it to you. So having seen this, what about the Glasgow study, which had evaluated the efficacy of PCSK9 inhibitor, evolocumab, by showing that there is an atherosclerotic cardiovascular burden, comes down by the reduction of the plasma volume, the atheroma volume. The next drug that was introduced as a PCSK9 inhibitor is alirocumab. This study was done in patients with acute coronary syndrome. Nearly 29% of the patients with diabetes, they received alirocumab subcutaneously, and compared with the placebo, they were able to bring down the LDL cholesterol to the levels less than 50, less than 30, less than 40, and less than 25, 15. These are the things which are depicted here. Those people who received this drug, when their levels were coming down to the 15, that was not the investigator's goal. So they pushed the patient to the higher level by reducing the dose. Like that, they were keeping the drugs for some time, and they followed up these patients, surprising the same amount of reduction of cardiovascular events, which were noticed in the 4-year trial, was also observed in the Odyssey trial. People who reach the levels less than 15 milligram, 1.5, there is an additional benefit, nearly about 29% risk reduction, not 15%. 15% was seen in the original study. In the analysis, subsequently it was revealed those patients who had levels less than 15 milligrams of LDL cholesterol, by using alirocumab, it was clearly seen that the reduction was coming down to 29%. So the message is very clear, ladies and gentlemen. If you use a PCSK9 inhibitor, either alirocumab or evolocumab, only evolocumab is available in our country. It is an injectable form, reduces LDL, VLDL, non-HDL, lipoprotein little a, remnant particles, LDL particle numbers. What more you want? Everything is almost coming down. The European Society of Cardiology and the European Atherosclerosis Society started coming out with a recommendation how much you should probably keep it for high risk, low risk, medium risk. The last one, what I thought I should tell you, is a very high risk individual. Aim for 50% reduction from the baseline. Keep the levels less than 55 in the year 2019. In 2016 itself, Lipid Association of India categorized this very high risk, started telling you that you should bring it down to less than 50 milligram. That's the most valid information what I thought I should share. In fact, in 2020, we came out with this algorithm. We have updated it. Low risk, medium risk, high risk, very high risk. How to do that? Please go through the website www.lipid.net. You will get this algorithm. All that you require is to keep this algorithm on your table and try to identify the patient who is walking in, whether he belongs to this group or that group or the other group. How to keep these levels? For example, if the person is having a low risk, moderate risk, try to keep the levels less than 100. The person is having high risk, keep the levels less than 70. Very high risk, try to keep the levels less than 50. If it is more than 50, try to intervene and then give them. We have introduced extreme risk group now, A and B. A with an established coronary artery disease with a high risk group, or a person with a very high risk group in the sense established coronary artery disease, polyvascular disease, diabetes with 3 more risk factors, target organ damage, extreme risk group B, where we recommend less than 30 milligram will be the ideal target through which probably you can give the maximum benefit for our patients. So this is how we are all justified in recommending 30 milligram for our patients based on all these evidences. In fact, it was approved or recommended or emphasized as the most important information by the Journal of Clinical Lipidology, USA. This is one of my patients, homozygous familial hypercholesterolemia, with a tendon xanthoma, with all the skin changes. She had seen me at the age when she was only about 11 years or so. She lost her sister in spite of the fact that I had told the parent that at any time the child would die because the LDL levels baseline was 720 milligrams. So homozygous, the other girl, after receiving treatment for a period of 3 months, she died. One fine evening, she died in the with severe chest pain. On the spot, she died. The drug that is now available to treat homozygous familial hypercholesterolemia is one, high dose statin. Yes, I have given 40 milligram. Ezetimibe, yes. Bile acid sequestrant, yes. And then I added PCSK9 inhibitor. You know the level of LDL cholesterol, what I reached in my patient? 191 now. I've added even bempedoic acid. So number of drugs are available. You need to give a combination so the patient should become all right. The drug that is now going to arrive soon, the drug that has been tried in homozygous familial hypercholesterolemia is evenacumab. This drug was tried apart from all this high dose statin, ezetimibe, plus your bempedoic acid, apheresis. These group of people have shown a maximum benefit, irrespective of the fact whether they had LDL receptors absent or present. In those group of patients, they had shown maximum benefit. So by using this drug, moderate intensity statin, you can anticipate 30% reduction. High intensity statin, 50% reduction. You give high intensity statin plus ezetimibe, you can expect 65% reduction in LDL. Only PCSK9 inhibitor for statin intolerant patients, 60%. PCSK9 inhibitor of moderate intensity statin, 75%. PCSK9 inhibitor, high dose statin plus ezetimibe, you can reach the maximum level of reduction of 85%. Look at the academic body's recommendation. Only ACC, AHA has not told you the target. It has recommended anybody who has more than 70 milligrams of LDL, try to keep it down. 50% reduction, aim for it. Is there a target? No. Whereas all other academic bodies, you can just see, all of them had recommended that you should chase the LDL cholesterol. The initial recommendation by ACC, AHA is that start high dose statin, fire and forget. Now, the revision is that they are keeping the levels above 70, try to treat. Bring it down as much as possible or 50% reduction. That's the recommendation, what is being made without giving 50, 55, 70 and all those things. Bempedoic acid is a new drug. I think it is also available in our country now. Even IPCA has produced this molecule. This molecule actually acts one step before the statin therapy. Actually, it is the ATP citrate lyase inhibitor. So a drug which was tried and recommended by FDA to be used in those patients in whom we are not able to get the LDL down of following myocardial infarction, or those patients in whom we have tried this drug, particularly familial hypercholesterolemia, or those people with a statin intolerance, you can always use it. Where is the evidence? Clear Harmony study, clear Wisdom study with a hypercholesterolemia, maximally tolerated dose of statin. They have shown a benefit of reduction of nearly 16% of LDL levels. They have also used it in statin intolerant patient. C-reactive protein also comes down. Yet another drug is inclisiran, which has not arrived in Indian market. Very soon you will get it. The advantages of inclisiran over the other PCSK9 inhibitor, evolocumab, is that it can be given once in 6 months. One injection once in 6 months. That's all. You get almost the same benefit as you get with the PCSK9 inhibitor. Instead of giving it once in 15 days, you can always go for once in 6 months. The drug is probably will be arriving soon in the second part of 2023. This drug is a wonderful drug. Having used all these molecules, non-statin molecules with the high dose statin, are we going to get the side effects of these drugs, bad effects of these drugs? Surprisingly, almost compared to the placebo, no problem except for the injection site reaction. Number one, if you use bempedoic acid, you may get an elevation of uric acid. If you use bempedoic acid, you may get a tendon rupture. These need to be kept in mind. Other than that, using a non-statin drug with a statin will not do any harm for your patients. This is the most important study called REDUCE trial, where everybody will be interested to bring down the triglyceride levels. REDUCE trial used icosapent ethyl ester, 2 grams in the morning, 2 grams in the evening, given for patients with diabetes with the ACS when their levels of LDL cholesterol reached nearly 70. They kept these patients for a period of 3.8 years or so. Surprising to see 25% reduction in the primary endpoint, 26% reduction in the secondary endpoints, thereby showing icosapent ethyl ester given in conjunction with statin, you do get benefit in not only reducing the triglyceride, but you get a maximum benefit in the primary endpoint. Because people in the lower levels of triglyceride also has shown benefit. This is a wonderful drug which I am also using it for my patients with hypertriglyceridemia. Last but not the least, LDL. Again, it is gaining much importance. This is the one that is to be evaluated in every patient. Please remember, at least once in his lifetime, please submit him for LPA estimation. You ask for isoform insensitive assay, which will give you the details of this molecule in the form of milligrams. The international recommendation is nanomoles and not milligrams. You cannot equate it with the nanomoles like you do pounds and kilograms. You cannot do that. People are now trying to come out with some sort of formula, but currently we are using only milligrams. LPA, the drug that is in the pipeline is pelacarsen, which is very good drug, it seems. Phase 2 studies have shown promising results. Recently, Stephen Neeson was talking to me over phone, and he also had shown a lot of interest in this field. When I was discussing in a panel discussion, I was talking about lipoprotein little a. He said, very good information that you had given about LPA. We are in the process of coming out with some results. He had used this SLN molecule, which has shown 85 to 90% reduction in lipoprotein little a. Do you have cardiovascular outcome data? No, we don't have it. This is Apollo study, where they used this molecule, Stephen Neeson and his group. So, ladies and gentlemen, in 2022, we are now entering into 2023. We have already entered. The drug that we have seen is a statin. The next one is estimide. The third one is a PCSK9 inhibitor. The fourth one is icosapent ethyl ester. The last one is a bempedoic acid. All the drugs are available now except the inclisiran, which will probably arrive in the second half of this year. So, ladies and gentlemen, my final message as far as the LDL cholesterol is concerned is lower the better, earlier the better, longer the better. Thank you very much, ladies and gentlemen, for patient listening.
Thank you, Dr. Rasingan, for an excellent display on the lipid management, and in particular emphasizing on the lower the LDL, better it is. I think unlike hypertension and diabetes, where we know the target more or less with consensus, in hypertension it is the target is less than 130/80. In diabetes also we prefer to have less than 7 and if possible less than 6.5. But in LDL cholesterol, we yet don't know how low to go. The lower is better LDL cholesterol, but how much lower to go is still not known. So the question I would request, since both Dr. Venkatram sir and he is not there, till the Governor Excellency comes, you can engage with the audience and yeah.
Ladies and gentlemen, we are expecting, in fact, no, we are expecting Honorable Governor, Her Excellency Dr. Tamilisai Soundararajan is probably will be coming within another 10 minutes or so to take part in this felicitation program, which we have arranged to felicitate Dr. V. Mohan. So before that, we need to take some questions from you because you have learned something from diabetes, something from hypertension, something from lipids. Probably before Madam arrives, let me now entertain some questions. The first question is from Dr. Soundararajan, who is husband of Dr. Tamilisai Soundararajan.
I'm here as a physician, right? Thank you. Enough to say that kidney is as much a sufferer like heart and brain. 138 is the target even for kidney, right? Diastolic blood pressure rise more than 80, 85, 90, nephron destruction starts, right? That's the one message. And as much the heart and atherosclerosis and the stroke, the kidney vessels also suffer from hyperlipidemia. We are conscious about keeping the lipids under check. It's a nephrotic, CKD, dialysis patient, transplant patient. We are also equally conscious. Enough to say that 2/3 of our CKD patients before they reach dialysis and transplantation die with cardiologist due to CAD. The dictum today is all patients with CAD should screen for CKD. All CKD must be screened for CAD. All CKD patients also must be screened for lipid profile.
Good afternoon, everyone. Let me have the pleasure of requesting our Honorable Governor, Her Excellency, Governor of Telangana and Lieutenant Governor of Puducherry to come to the dais, please, to be accompanied by Dr. Venkatesh Ram and Dr. Mohan. Sir. Let us have the national anthem. I request all of you to stand, please. Followed by Tamil Thai word.
शुभ में जागे शुभ आशीष मांगे जय जय நீராடும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராடும் மலரமென திகழ்வரத தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற பெரும்
please. Let me now request Dr. Venkateswaran to honor our governor with a shawl and bouquet, please. Thank you. So ladies and gentlemen, I have great pleasure in talking about Her Excellency, Dr. Tamilisai Soundararajan, who is the governor of Telangana and Lieutenant Governor of Puducherry. Dr. Tamilisai Soundararajan assumed the charge of Lieutenant Governor of Puducherry Union Territory on 18th February 2021, bringing alone with a rich and varied experience to the office of Lieutenant Governor. Apart from her duty as a governor of Telangana, she had assumed office at Puducherry to take the post as the Honorable Lieutenant Governor. Born in the year 1961, June 2nd, born in Kanyakumari district in Tamil Nadu. I think her father is known to everyone, Dr. Kumari Anandan. Dr. Tamilisai Soundararajan has been actively involved in public service of early days, keenly observing the issues that concern people since her childhood. Dr. Soundararajan too got elucidated spirit of activism and service from early on. She is known as a passionate leader with a lot of compassion towards the downtrodden, underprivileged section and others in distress. She was a doctor by profession, and we are all very happy that a doctor has become the governor. Doctor has become the Lieutenant Governor. We are really proud to have you here, madam, with us this afternoon. She began her career as a medical practitioner after completing MBBS and DGO. She had rendered service as in government in Ramachandra Medical College as assistant professor, and later she resigned the job. Political entry to serve the underprivileged. I think all of us know about her activities in the major politics in our country. Madam has authored many books. She is a good prolific writer, an avid reader of a wide variety of books. She wrote academic books related to her medical profession, as well as a couple of books on Honorable Prime Minister Shri Narendra Modi ji on a variety of subjects. She is a powerful orator, debater, and anchor. Tamilisai Soundararajan proved her mettle as a forceful orator and as a powerful debater in television channels and gave many radio talks. Dr. Tamilisai Soundararajan, Her Excellency, has served as a Vice President of the Tamil Literary Forum. She is a multi-talented and versatile personality with a passion for excellence in whatever she does, winner of International Rising State Award. Give her a big hand, ladies and gentlemen. Dr. Tamilisai Soundararajan was conferred with the top 20 Global Women Excellence Award in 2021 from United States of America. The award was presented on the recommendation of Multi-Ethnic Advisory Task Force. The award was conferred based on her contribution towards women's rights, towards gender parity, women empowerment, and women equality, core areas of focus. She is a good administrator of Indian values and traditions. Dr. Tamilisai Soundararajan is a great admirer of invaluable social and cultural strengths of our country, and a strong votary for the inclusion of India, a value system, culture, traditions, and humility, right from the basic education and further. Ever since she assumed office as a Lieutenant Governor of Puducherry, she has been a winning hearts of the people and is turning out to be popular people's governor. Madam, we are really very happy to receive you here this afternoon. I have the pleasure of introducing Dr. Venkateswaran. Venkateswaran is known to most of us If you want to read something on hypertension, definitely you would have seen number of articles published by Dr. Venkatesh Ram. You would have seen the contribution by Dr. Venkatesh in various textbooks for various chapters on hypertension. He is the best person in the field of hypertension, a pioneer in the field of hypertension. Not only that, he served Apollo Hospital, a group of hospitals for a number of years, and he was based at Hyderabad for many years. Now he is in charge of Apollo hospitals globally as an academic coordinator. Over and above, he still has an affinity towards United States. He still goes to Texas and actually has his own center where he had taken training under Norman Kaplan, a pioneer in the field of hypertension. He still has an interest to teach. He is a faculty in the Australian University in the field of hypertension. Dr. Venkatesh Ram is the most enterprising person, down-to-earth person, good friend of mine. Sir, we welcome you, sir. Dr. Mohan, can I request you to honor Dr. Venkatesh Ram with our Honorable Governor? Now, the most important event for this afternoon is to felicitate our friend in the field of diabetology, Dr. V. Mohan. Dr. V. Mohan's achievements are many. In fact, if you look at the internet or try to look at the achievements what he had made, it's very, very difficult to summarize it also. That's why I requested him, why not to send just a small summary before I dwell into the areas where he has shown lots and lots of achievements. Dr. V. Mohan is the chairman of the Chief Diabetology at Dr. Mohan's Diabetes Specialties Center at Chennai in South India, and which is an IDF center, International Diabetes Federation Center of Excellence in Diabetes Care. Dr. Mohan oversees a chain of 50 diabetes centers across 8 states of India and has over 585,000 patients with diabetes, registered case in his centers. He is also the president and director of the Madras Diabetes Research Foundation, which is Asia's largest standalone diabetes research center. His main research interests are epidemiology of diabetes and its complications, genomics of diabetes, including monogenic diabetes, type 1 diabetes, fibrocalculous pancreatic diabetes, precision diabetes, and nutrition in diabetes. Deeply interested in research from his undergraduate medical student days, Dr. Mohan has published over 1,530 papers. Ladies and gentlemen, I don't think any scientist in our country has reached this level. He's the only person. I think only one more person is probably has gone 5 or 10 papers before Dr. Mohan could reach that level. I am sure with the God's blessing, Sai Baba's blessing, you will reach that greatest height in your achievements. Among these 985 are original articles. His research has attracted over 173,000 citations, 173,000 citations, and has in the H index of 144. Dr. Mohan is ranked among the top 2% of the scientists in the world and among 0.1% of the researchers in type 2 diabetes by Expertscape, that is PubMed. Dr. Mohan has trained a large number of physicians and diabetologists in addition to nurses, educators. He has received over 200 awards, including the prestigious Dr. B.C. Roy National Award by Medical Council of India and Dr. B.R. Ambedkar Centenary Award, the highest award of biomedical research given by ICMR. He was conferred Dr. Harold Rifkin Award by the American Diabetes Association. He was also conferred FRS from the Royal Society of Edinburgh. for his extensive contribution in the field of diabetes. In 2012, Dr. Mohan was awarded Padma Shri by the Government of India. Give him a big hand, ladies and gentlemen. Dr. Mohan's autobiography, Making Excellence a Habit, The Secret to Building a World-Class Healthcare System in India, was published by Penguin India. His latest book is Banting, Bows and Beyond, was published by Notion Press. Both are bestsellers on Amazon. Dr. Mohan, we are really very proud to have you here. Thank you very much for responding to our invitation. And you are going to be awarded by none other than our Honorable Governor of Telangana and Lieutenant Governor of Puducherry and Dr. Venkatesh Ram. Dr. Venkatesh Ram is another Padma Shri awardee. So I am really happy to have two Padma Shri awardees with the governor. I am lucky to be here with all three of you. Dr. Venkatesh Ram, can you just talk something about the World Hypertension League, which had come forward to felicitate Dr. Mohan, please?
Thank you very much, Dr. Nursing, and ladies and gentlemen. This occasion is happening especially because the World Hypertension League has asked me and Dr. Narsingan to recognize Dr. Mohan's contributions to public health. World Hypertension League is an organization, umbrella organization, that is almost all the hypertension societies in the world come under World Hypertension League, and all its activities are in alliance with World Health Organization. So in terms of the high blood pressure dissemination information, it is the main platform and the main mouthpiece for all the information that goes to different countries, including sub-Saharan countries, South Asia, etc. So World Hypertension League and World Health Organization have recognized Dr. Mohan's contribution. The current president of the World Hypertension League, who is the expert on guidelines, is known as a guidelines guru. Dr. Paul Welton, who is a guidelines guru, has looked at Dr. Mohan's so-called brief CV. He always says brief CV, and he looked at Dr. Mohan's brief CV, and he and I discussed that, and he told me that we need to honor Dr. Mohan on behalf of World Hypertension League. So that is something that is coming not from me and Dr. Narsingan, but it is coming from the president of the World Hypertension League, Dr. Mohan. Thank you. And I also, remiss to mention that Narsingan is the first Asian to be the elected vice president of the World Hypertension League. I forgot to mention. And a couple of personal things I want to mention about Dr. Mohan is that he's a brand, of course, we know that. Once upon a time, if you came to Chennai, which I knew as Madras, you will give landmarks as near Higginbotham's, near Spencer's, near Gemini Circle, near various highways. But now the landmarks are near Dr. Mohan's clinic, left to the Mohan's clinic, right to the Mohan's clinic. In fact, I used to live in a house in Jubilee Hills. I used to tell people it is on the street just in front of Dr. Mohan's clinic in Jubilee Hills. So he's become a landmark. And the most important thing, he transfers the knowledge to other people. That is very important. Knowledge keeping to oneself is stagnation. Knowledge giving to others is called skill. And he has that skill. And he has given a late legacy for country, saying that we are second to none. We are second to none in terms of medicine, in terms of diabetes. And he has given such a pride for people of India that we should all be proud that we never accept second to none. This is in line with the government of India. And then I don't know if any Hindi speaking people here. No, sar jhuka ke mat jiyo, muh chupa ke mat jiyo. That is what Dr. Mohan is. He does not. And a beautiful name, Mohan itself, which is in Tamil Mokan, which is all we desire, loving exemplary, etc. And of course, we have wonderful Mohan Ragam, anyway, which everybody likes. So, ladies and gentlemen, it is really a privilege for the World Hypertension League to recognize Dr. Mohan for his achievements and bless him with continued achievements.
Thank you for the kind words. Yeah. Let me now request our Honorable Governor, Dr. Tamilisai Soundararajan, to felicitate Dr. Mohan by giving him the shawl and the scroll which has been presented by our Excellency. I'm going to read it out. As the Vice President of the World Hypertension League, I have great pleasure in reading out this citation, a small citation from WHL. WHO Alliance is pleased to bestow the Special Recognition Award to Dr. V. Mohan for his notable, enduring, and impactful contributions to the field of cardiometabolic medicine. His lifelong research of world-class and clinical work has resulted in improved care of patients with diabetes and comorbidities. Dr. V. Mohan, we owe you a debt of gratitude for your inspirational, for your passionate, and for your historic service to preserve and protect the global public health. Signed by Paul Welton, the President. Of course, I also had signed it in the capacity as Vice President. And of course, Padma Shri Dr. Venkatesh Ram has signed this document. Please accept it on behalf of WHL. Before our Honorable Governor gives her chief guest address, I thought it is my duty to show a small video of Dr. Mohan. After that, I can request Honorable Governor to felicitate Dr. Mohan.
God could not be everywhere, so he sent us doctors. Doctors are an incarnation of God who save. God could not be everywhere, so he sent us doctors. Doctors are an incarnation of God who save lives with their knowledge, wisdom, experience, and healing touch. Dr. V. Mohan, a formidable name in the field of diabetology, is in a different league altogether. For many decades, he has been relentlessly making a huge impact on the understanding and practice of diabetes management. They say, like father, like son. Dr. V. Mohan is a living testimony of this saying, as he was deeply inspired by his renowned father, Dr. M. Vishwanathan. He started working on diabetes at the age of 18 as a second-year medical student when he assisted his father, Professor M. Vishwanathan, who is considered the father of diabetology in India. After spending 20 great years with his father, he established the well-known Dr. Mohan's group of diabetes institutions in 1991 ably supported by his late wife, Dr. Rema Mohan. Dr. V. Mohan is one of the leading names in medical research in contemporary India. He is the president and director of Asia's largest standalone diabetes research center, Madras Diabetes Research Foundation. Dr. V. Mohan is also the chairman and chief of diabetology at Dr. Mohan's Diabetes Specialty Center located in Chennai. He oversees a chain of 50 diabetes centers across 8 states in the country. He has over 5,85,000 registered patients in his centers. Being the director and president of Madras Diabetes Research Foundation, his main research interests are the epidemiology of diabetes and its complications. Deeply interested in research from his undergraduate medical student days, Dr. Mohan has published over 1,530 papers in peer-reviewed journals, including 985 original articles. His research has attracted over 1,67,000 citations and has an H index of 144. Dr. Mohan is ranked among top 2% of scientists in the world and among the top 0.1% of researchers in type 2 diabetes by Expertscape PubMed. He has also trained many physicians and diabetologists in addition to nurses and educators. His contribution to the field of medicine has been applauded by many. He has received over 200 awards, including the prestigious Dr. B.C. Roy National Award by the Medical Council of India and the Dr. B.R. Ambedkar Centenary Award, the highest award for biomedical research given by the ICMR. His research and in-depth understanding of the field have brought him international laurels. He was conferred the Dr. Harold Rifkin Award by the American Diabetes Association and the FRS from the Royal Society of Edinburgh. For his extensive contribution in the field of diabetes, in 2012, Dr. Mohan was awarded Padma Shri by the Government of India. Dr. Mohan's autobiography, Making Excellence a Habit, The Secret to Building a World-Class Healthcare System in India, was published by Penguin India. His latest book, Panting, Bose and Beyond, was published by Notion Press. Both his books are bestsellers on Amazon. For his notable and impactful contribution to the field of cardiometabolic medicine, the WHO Alliance bestowed upon him the Special Recognition Award. We express our heartfelt gratitude to Dr. V. Mohan for his inspirational, passionate, and historic service to preserving and protecting global public health.
I think the time has now come for the chief guest to say a few words about Dr. Mohan and WHO Alliance and the role played by Dr. Venkatesh Ram for this important event. Over to you, ma'am.
Special good afternoon to each and everyone here. Dr. C. Venkatram, Director, World Hypertension League, Southeast Asia, and Dr. S.N. Narasimhan, Vice President, World Hypertension League, Dr. V. Mohan, Director, Mohan's Diabetic Center, Dr. Mohan being felicitated by the World Hypertension League on behalf of his contribution in the field of diabetes to the globe. And when Dr. Narasimhan introduced Dr. Venkatraman and Dr. Mohan, and he said, Padma Shri, introducing the Padma Shri, which was introduced by the future Padma Shri, I think, because of your contribution. And I thought when I entered the venue, I'm in a very dangerous zone because that time, that side diabetes, this side hypertension. So we have to be very safe. So side by side, hypertension and diabetes, we have to be very careful. So that is the message. It's a very simple message. So it is, I'm really very happy to attend this program. And I thought, because yesterday I have sent a video message, and today my schedule was very tight. But in spite of that, because of Mohan's contribution, not only to the field of diabetes, the education, here educating the patient, educating the society, how to control diabetes or how to pre-diabetic stage and how to avoid diabetes. I have seen most of his videos. And personally also I know him. And my husband, Dr. Soundararajan, he's also have come here. And he's sitting there. I always say, there is a provision in the constitution. When the governor is attending a program, there is always a chair nearby for a Madam Governor. But Dr. Soundararajan always sits in the audience because he says, I also have found, most probably they would have thought lady governors won't be there. So there is no chair for a Madam Sir Governor. So always you would have seen governors will be accompanied by lady governors. But lady governors very rarely accompanied by their husbands because he always preferred to sit there. But in spite of that, because he was very much, he also very admires Dr. Mohan. And because of that, we came here. And I'm really happy that he is felicitated by the World Diabetic League. And what I have to say about Dr. Venkatraman, because he is, as Mogan, because as Mogan means it is diabetes, Venkatraman means it is hypertension. So these both diseases, preventable diseases, are now the most common diseases. And as doctors, we know that the awareness should be spread among the public. And whenever persons like Mohan or Dr. Venkatraman honored, it is the message to the people that they also should be very careful in maintaining their health. And I have to say, because the number of papers he has presented, a number of scientific papers published, actually it is really exemplary work. I don't know, when we calculate the days and hours he worked and the number of papers and the number of publications, I don't know per second how he works. Every second or I think it's very difficult to calculate it. So I'm really very happy, and it is shown that I also know his father is father of diabetes. So it is that it is not easy to carry the legacy also, I know, because everyone will say, no, there's so-and-so's father, so-and-so's son. So it is very easy, but I have had an experience because it is very difficult. It's not that father is father of diabetes, so he has acquired that habit of reading diabetes or learning diabetes, because the recognition is also very difficult. For example, because I am a politician's daughter, so when I used to go for elocution competitions, first of all, I will be graded as first person who did very well. And when my teacher introduces, usually my teacher introduces that, no, you know, it's so-and-so's daughter. Then immediately that judge will strike away my name. So if she is so-and-so's daughter, she would have done better. So always we have lost. So it is not easy to be a great person's children. It's very difficult because they are so great. So to reach that greatness, it is very difficult. So hard work is needed. So Mohan, definitely it would have been a very difficult, because I can pulse it. So it is very difficult, but you have made it because his father is the father of diabetes, and he had his training under him. And I remember that I have met his father along with my father. And first time I saw in a clinic, apart from the clinic, there was a teaching room. So that is the importance of creating awareness among the public. I always say, whatever may be the disease we suffer, but awareness about the disease is more important. Not only the tablets or the medicine which we take, because awareness is very important. For example, when we were students at Tanjavur Medical College, we used to give iron tablets to the patients, identifying anemia in them in the pregnancy stage. And when we go for lunchtime, most of the anemia tablets would have been thrown in the grounds. And we used to pick it up and we used to call the patients, why did you throw? Then they used to tell, no, already this is dark in color. My mother-in-law told, if you take this tablet, your child is also will be dark because it's black in color. So if you take the medicine, your daughter or son will be black in color. So in a lighter sense, I appealed the pharmacist for, so please don't produce iron tablets which is black in color. Please produce iron tablets which is colorful. So ladies do colorful saris and they are more colorful. So at least we will compel them to take because it's colorful tablet. Because making them aware, because awareness is very, very important. When I was practicing as a sonologist at Tanjavur, I asked one person, because that was the initial days of ultrasound. I asked one patient saying that I have to study your prostate. So tomorrow you come with full urine. Next day he came and opened a yellow bag, put one Horlicks bottle of urine, second bottle, third bottle. Then he told, no, you only told doctor, come with full urine. So I have got, so why I am telling this, making the people aware of the situation is the most difficult one. It's not the treating. And nowadays, having the Google by side, it is very, very difficult. So when we say some diagnosis, they will tell, no, sir, no, madam, Google says like this. So we have to compete with Google in making the people to understand. So nowadays they think they are half doctors. It's very easy to treat the ignorant people. It is very difficult to treat some people half intelligent or most intelligent or Google intelligent. It's very difficult. So we are facing with more challenges. It's not the medical practice which was just few decades back. It is very difficult. But in that situation, Dr. Mohan, because I know Dr. Mohan as a Sai devotee, and after meeting him, I became a Sai devotee. And he was telling me, because my name is Tamil Isai Soundarajan. Honorable Prime Minister asked me, are you a Sai devotee? Because Tamil Sai Soundarajan. I told him, Tamil Isai only. Somehow Sai blessed me. So Sai is within me. So he is blessing me. So he also told, so this is, most of the people, when I went to Telangana also, they pronounce me as Tamil Sai Soundarajan. It's Tamil Isai Soundarajan. So that affinity also, that we are devotees of Bhagavan. And I'm really very happy. And I have noticed most of his videos. And I have shared those points with some of the VIPs also. Recently, he told, now recently he has told, after eating, slow walk for 5 minutes. So that will prevent diabetes. These are small things, because small things which if we make the people to be aware. Because I always tell a small story. One farmer wanted to sell his land because he was starving and he was very poor, and he called an advertisement agent and he told, I want to sell this land. Without selling this land, I cannot thrive. So this advertising agent, you know how they used to write. He was writing, this is a piece of land which is near the railway station. Near the railway station, it will be 50 kilometers. It is near this school. And there are two trees, mango tree and guava tree all in the field, in the land. And there is a well in the Isan Mulai, that is Vastu. And everything he wrote and beautifully written advertisement. And he gave it to the farmer and told, please give the fees for the advertisement. Seeing the advertisement, the farmer told, no, I am not going to sell the land. The reporter got angry. The advertising agent got angry. He told, just few minutes back only, you told you are going to sell this land, and without selling this land, you cannot thrive, you are poor and you are suffering. And now we are telling, after this advertisement, you are telling you are not going to sell the land. Then that farmer told, I don't know, such good things are there in my farm. After you make me aware because of this advertisement, now I am thinking why I should sell the land. So this is the situation. About our body, we know everything about our heart, stomach, everything. But alerting the patient, advising the patient, making them aware. Nowadays, I have seen it is making awareness is more important than treating the disease. I think Dr. Venkatraman also will accept it because he's also have done lot of work on hypertension. And I think he's very cool. So only he's working on hypertension. And he's my neighbor. Because not here, it is, he's my neighbor in Hyderabad. So I'm really very happy to attend this program. And Mohan is a role model. And not only treating. Most of our Indian medicine, we are unable to prove because it is not shared. Some good things, or even some of the our associated medicine, some of the herbal medicine also, which is really useful. It is not shared. Most of them say, no, this is our family property. But Mohan has shared his family property, the diabetes, to each and everyone. So I'm really very happy. So this type of awareness should be created by the physicians, by the medical fraternity, and the people really are benefited by your service. And I came here not only as a governor, I came not as a doctor, I came as a personal friend of Dr. Mohan, as well-wisher, and very rarely myself and my husband come to a program because he will be practicing and I will be roaming here and there. And because of Mohan, we both on a Sunday we came. So this is a great compliment to you and really very happy. So that more laurels, we are already having a long list. So if I wish, how the link list will be added. So whatever may be the situation, your service is needed for the society. And I really appreciate your service and you appreciate now the social media, your awareness videos and in the YouTube, your awareness programs. And I'm really very happy to attend this program. And with all my busy schedule, I'm really happy that I could make it possible. Thank you so much.
Thank you very much, ma'am, for the excellent appreciation and congratulations to Dr. Mohans. And may I now request our hero of the day, Dr. Mohan, to come to the dais, please.
Respected Honorable Governor of Telangana, Dr. Tamilisai Soundarajan, and also Lieutenant Governor of Puducherry, my very, very good friends and colleagues, Dr. Venkatram and Dr. Narsingan, Dr. Soundarajan, all the distinguished doctors, including some of my students in the audience. I must say I am very, very humbled today. Madam's gesture of cancelling her direct trip from Puducherry to Hyderabad and to come here specifically for this, and she has openly said that, I think is one of the most humbling experiences, and that shows how humble she is. I'm extremely grateful and humbled by the World Hypertension League. It's also very encouraging that people, when you do good work, it is noticed by people. Our Honorable Prime Minister always says that, our Honorable Governor always says that you don't have to really advertise. And the story she said about the farmer, I think, is very appropriate here. But if you do good work, people do recognize it and people do. And so I'm very, very grateful to the President. Please pass on my personal thanks to him for this unique gesture, because I roamed for a few months. You have been talking about this. How do we have this function? How do we, in fact, he invited me to Amritsar once. I could not go there. And so especially this function was organized for that. And to Dr. Narsingan as the incoming Vice President, congratulations, sir. It's a great honor. I know the World Hypertension League is like the IDF, that like the International Diabetes Federation, that we have all the associations in the world coming together. And for an Indian to be reached there, to the level of Dr. Venkatram and Dr. Narsingan is not easy. And therefore, we can be very, very proud that one day soon we'll have an Indian president of the World Hypertension League. I'm sure from vice president to president is only the next step. I'm very, very grateful to Madam and to Dr. Soundarajan for making it making their presence felt here and to attend this function. Madam has been very kind to me. I don't know how many of you are on Twitter. Whenever a nice post comes, generally people who are busy and who are in a position may not even like it, let alone retweet it. Madam not only retweets it, she adds a line to it and says, I like this, I appreciate this. I don't know how she finds a time amongst her very, very busy schedule. And then people then retweet that saying, Madam has retweeted. So then they take photographs of that and send it to me. And all that just shows her love and affection. And I distinctly remember your father visiting Roypuram, Madam. I was there with my father when we received him there. So it's been a long association with the family. And of course, Professor Soundarajan is my daughter's teacher at Ramchandra Medical College and a very fantastic nephrologist who has done so many cadaveric transplants, kidney transplant. I don't think anyone else has done the number that he has done. So I'm in very august company, and it's therefore very humbling. Just a couple of words, because although, when you're a head of an institution, you tend to get all the laurels and all the glory and all that. We often forget that there's a huge team working for you, and it's they who have done all the work. And very often the chief gets all the glory of the work done by everyone else. And I often tell my team that I am only a postman. They gave me some award, I'm bringing it to you. So I am the courier boy or the postman. All the work is for you, the award is for you. I just go there, collect it and bring it like a postman to you. I don't actually deserve the award. All the work is done by you. But on a more serious note, just 3 or 4 people I just wanted to thank. Whenever you're honored, you think of how did you get there? The first and foremost is my spiritual guru, Bhagavan Sri Sathya Sai Baba. Although only for about 30 years, I've been officially his devotee. Right from my childhood, if you've read my book, Sathya Sai Baba Lives On, which is now in 10 languages, by the way, translated in 10 languages. It's supposed to be one of the most popular books on Baba now. Right from my childhood, he's been there. From the time I was 5, 6, he has played and continues to play miracles in my life. Every single day is a miracle. Madam coming here today is a miracle. Every single day not passes without, and Dr. Varalakshmi, my colleague, is sitting here. Every day I'll tell her, today's miracle is this. And I'll show her the picture as a demonstration of that. So I think it's his love and grace which has helped, and somebody in fact filed an RTI saying it's not possible for a human being to publish so many papers, investigate him. There's something wrong with him, And then the government of Tamil Nadu actually investigated. And then they prepared a file. And then the reply to him was, yes, some people can do it. And so that someone who can do it is only because of divine grace. I don't think as a human being, anybody can do it. But with divine grace, anything is possible. So my pranams to his lotus feet. I was just calculating this morning. 20 years of my life was with my father. And so he is the greatest. And from 1971, when I joined Medical College, Madras Medical College, to 1991, when I left him to start my own, 20 years of that life he was the one who was my medical guru and has brought me to everything that I knew about diabetes is due to him. And therefore, I can't but mention him. Strangely enough, the next 20 years, and I was just calculating this morning, it's exactly 20 years, 1991 to 2011, when Rama passed away, was the next phase of my life. And it was she who actually, when I left my father, I joined medicine only to help my father. So when I wanted to leave my father, he said, if you're so smart, you just pick your stethoscope and leave. I'm not giving you anything. Let's see how smart you are on your own. Later on, he confessed to me a few years later, I did that so that you will work hard. Otherwise, if I give you everything on a plate, you will not work hard. So he said, that's a secret, which I said. But actually, I had to leave with just my stethoscope, nothing in the bank, nothing. And the entire thing which we built up from Dr. Mohan's was due to Baba's grace and Rama for the next 20 years. So I was telling my daughter, Dr. Anjana, and my son-in-law, Ranjit, who after 2011, it's been them. It's my Anjana who has been literally running the research, the centers, the growth, the administration, the patient care, almost everything, the family, everything single-handed she has been running. So I said, okay, so it looks like the next 20 years. She said, why 20? It should go much beyond that. So the last part of my life after 2011 has been due to Anjana and my son-in-law, but of course a huge team. Lakshmi is here and many others are here. So a big thank you to MDRF staff, DMDAC staff, but for all of you, I don't think I'll be either here today, standing in front of you, or I could have achieved even 1,000th of what I have done. So thank you very much again to the World Hypertension League and the WHO Alliance, to Dr. Venkatram, to Dr. Narsingan, and big thank you. This was totally surprised. When I entered the hall only, they told me, didn't expect this at all. So the governor, Madam Governor, to be here along with Dr. Soundarajan. So I consider it a red letter day in my life, and I think it's one more of Baba's miracles. Thank you, Sairam.
Thank you very much, Dr. Mohan, for the inspiring talk. Now we are coming to the end of the function. Let me have the pleasure of proposing a word of thanks. It is my duty to appreciate and the time that has been allotted to this function by our Honorable Governor, Dr. Tamilsayi Soundararajan. The time that Dr. Venkateswaram had taken to travel from Hyderabad to this place, thinking all about this function. Every time he used to call me and then ask me what was happening. Is he coming? Is he coming on time? Did you receive this, that? That sort of encouragement and the involvement, that's most important, that you had it. You made this function a grand success. Thank you very much. And of course, I must thank Dr. Mohan for accepting the kind invitation that has been given by Dr. Venkateswaram. It has come from him, not from me directly. Of course, I had to tell him that I am the vice president for this particular organization. Since he already talked to you, I thought I should do it a little later. And of course, I had an opportunity to meet him day before yesterday in Epicon during dinner time. I discussed and then requested him to send his biodata in a smaller manner so that I can be in a position to read it out quickly. And that is the achievement what he had. And I am really happy that Madam has devoted her time. Dr. Venkateswaram has devoted his time to come here. Of course, Dr. Mohan requires a special mention. Number of awards he would have received in his life. But what I feel, the world recognition is the most important. A different field, World Hypertension League is a different field. I'm not talking about American Diabetes Association or International Diabetes Federation. I'm talking about the World Hypertension League had recognized another specialty person who has to be acknowledged and who has to be appreciated during this meeting. I'm really happy that you responded to our invitation and be with us for this wonderful function. And of course, you were mentioning about your father before you left your MB hospital for diabetes. Of course, I was there as an associate professor for that time when Professor Vishwanathan introduced the diploma course in diabetes. One day evening, he asked me, Narsingan, can you find some time to come and see me this evening? By 7 o'clock, I'm sitting in the prevention of diabetes clinic. I went there to see him. Sir, I have a news to you. Yes, sir. Dr. Mohan wants to leave this place. I'm terribly upset. What is your impression about it? Thank God you have not asked me advice. You have asked me only impression. Because Vishwanathan will not come down and ask you advice and all. Because he had his own approach. I said, sir, appropriate time, a good decision is to send him out of this place so that he will come with flying colors. I told him on that day, it has come as truth today. Dr. Mohan, you have ascended to the top level. And if you had been there only in that institution, probably you would not have come to this level. That's what I presume. So thanks to your father who is in heaven. Thanks to your family. I used to always remember Dr. Rama Mohan. Even this morning when you walked into this place, I was just wondering if Rama Mohan had accompanied Dr. Mohan, it would have been nice. A partner is always a person who will always console you for each and everything. I think that is one thing which I was reminded. And I'm really happy that all of you had assembled here and graced this occasion and make it a big success. Last but not the least, this morning around 11 or 11:15, I called I think 10:15. called Dr. Soundararajan. Sir, madam is coming. Can you make it for this meeting? Is it possible to come? I'm coming. I'm in another seminar. I'm coming. Sometimes no, I used to tell him only in the last minute because he is there in our API. I am the secretary. He is the only executive committee member. So I can even request him, order him to do that also. And immediately obliged. Nursing, sir, I am coming there. Don't worry. So that sort of cooperation, like-mindedness, friendly approach, and down-to-earth person I made to see in my life. Thank you very much, Dr. Soundararajan. Yeah. The program initially was started with a conference of Cardiometabolic Digest 2023, where 3 of us gave a talk, started by Dr. Mohan on diabetes, followed by Dr. Venkateswaram on hypertension. Finally, the topic was on lipids, because I was about to be bridged between these two, but they put me in the last. Doesn't matter because lipids play an important role. And that's the number 1 risk factor for cardiovascular disease, almost with hypertension. And diabetes goes a little later. Mohan, hope you will not mistake me. So nice. Thank you very much, ladies and gentlemen, for your patient listening here for the conference. And your August presence made a big success here. Thank you very much once again. Yeah, this conference was initiated and made as a big event for Chennai doctors and doctors across the country. Many of them were actually going through these webinar programs like that. Many of them were witnessing what I spoke, what others spoke, and still they are on the line to watch how things have been done, how Dr. Mohan was felicitated. This is a wonderful opportunity what IPCA people had given to us. Give a big hand, specifically to Mr. Johnny and his team, and most importantly, the medical director, Dr. Parikh. So with this, let us have the national anthem before Madam leaves.
Jana Gana Mana Adhinayaka Jaya Bharat Bhagya Vidhata Jaya Sindhu Gujarat Shubhamane Jage Shubha Ashish Mange Jaya Dhamma Jaya 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 Jaya